And so with that, may I invite Dr. Ajay Kher to please start his presentation.
Thank you, Dr. Jha, for the opportunity for not just this talk, but also to do the whole series on fluid electrolytes and acid base. And I hope I do justice to the excellent introduction and all the praise that you just poured on me. And I hope I live up to the expectation. So today I will start with how water is distributed in the body. Then we'll talk about volume regulation and osmolarity regulation. And then we'll focus on that hyponatremia and hypernatremia are water problems. And I think unfortunately the name has sodium in it and leads to confusion. So I'll try my best to relate to everyone that hyponatremia and hypernatremia are water problems and need to be thought of as such. And then at the end, I'll talk a little bit about steady state. And I think that is one of the key concepts for all physiology, but I'll try and highlight it with a few examples from some balance studies. And then I'll take questions at the end. So I'll start with a case, a case that all of us will see on a daily basis. And I'll pause at the end to let people kind of have a paper and pen and choose what their answer is. A 60-year-old who is an 80-kilogram male with heart failure and presents with pedal edema and pulmonary edema and has some about 10 kgs extra on board. He gets intubated on arrival and Lasix or furosemide is initiated. He has a urine output of 150 ml per hour that continues. His initial sodium was 140. And then the next day it's 146. The diuretics are continued. He continues to have about a 3.6 liter output. And the next day, which is now day 2, his sodium is now increased to 153. So how would you treat him? A, would you stop his diuretics? B, would you stop diuretics and give him free water? C, would you continue diuretics and give no free water? And D, would you continue diuretics and give him free water at 150 ml per hour? So I'll give a few minutes. And hopefully by the end of the talk, the answer will be clear and we'll be able to come back to this patient again. Okay, so I'm going to now start with how water is distributed in the body. So for a 70 kg person, about 42 liters, which is 50 to 60% of the body weight, is going to be distributed in the is going to be the water. And then of that, 60% is going to be in the intracellular fluid compartment, which is about 25 liters. 40% of that is going to be in the extracellular fluid compartment, and that is 17 liters. Of these 17 liters, which is in the extracellular fluid compartment, 30% or 13 liters is going to be interstitial compartment, and 10% of the total 4 liters is going to be in the plasma. This is important to note that the reason these distributions are such are dependent on what particles and solutes are in each compartment and are limited to which compartment. So sodium, which is the key for extracellular fluid compartment, is actually kept in the extracellular fluid compartment by the sodium potassium ATPase, which is going to push the sodium outside the cell and keep it in the extracellular fluid compartment. And in the intracellular fluid compartment, we have potassium and proteins, and they dictate the amount of fluid that is in the intracellular compartment. So hence, the key concept is that the extracellular fluid compartment and the amount of volume that is there is actually dictated by the amount of sodium that is in the body. This is something that I will continue to repeat throughout the talk, that the amount of sodium in the body dictates the extracellular fluid compartment and the extracellular fluid volume. So next, let's look at how will 1 liter of whether it's water or 5% dextrose distribute when you give it to someone. So again, now we are looking at the same 70 kilo person, and this is an intracellular fluid compartment, the ICF, and the osmolarity is 280 milliosms, and 25 liters is in the intracellular compartment, while in the extracellular compartment there is 17 liters, and the osmolarity is again 280, and water is free to distribute across all compartments. So now when we add 1 liter of water, whether it is oral water or whether it is by 5% dextrose, because the dextrose is going to be taken up by the cells and metabolized, and so the free water is going to be left. So how does that distribute? So when that goes into the body, that water will distribute like the rest of the water, and 60% of that will go inside the cell. And so now it will be 25.6 liters, and 40% will be in the extracellular fluid compartment, and it will become 17.4 liters. And the osmolarity, which was 280, will get diluted to about 273, because that water is now distributed across and it is diluting both the intracellular compartment as well as the extracellular compartment. And so this is how plain water or D5 will distribute. Now let's look at how 1 liter normal saline will distribute. So again, we have the same 70 kilo person with 25 liters in the intracellular compartment and 17 liters in the extracellular compartment. And now when we give him 1 liter normal saline, because the normal saline is limited only to the extracellular compartment, so what will happen is that all of this 1 liter fluid will remain in the extracellular compartment. And as the osmolarity is isoosmolar, the osmolarity will not change. And this person now has 18 liters in his extracellular fluid compartment. So now let's think about how 1 liter of half normal or 0.45 normal saline will distribute. So we need to think about half normal saline as being made up of two fluids, 500 ml of normal saline, which will only remain in the extracellular compartment, and 500 ml of water, which will distribute like water distributes, 60% in the intracellular compartment and 40% in the extracellular compartment. So net total 1 liter, 2/3 of it is going to be in the extracellular compartment and 1/3 will be in the intracellular compartment. So this is how the fluids which we give every day, how they distribute. And this is why when we choose fluids for expanding the extracellular compartment or intravascular repletion, normal saline is the best fluid out of the ones that we talked today. So now we'll shift gears and talk about how the body senses and regulates this extracellular fluid volume. And we'll talk about, again, the key fact, which is that the extracellular fluid volume is dictated by the content or the amount of sodium in the body. This extracellular fluid volume is sensed by or sensed as effective circulating volume, and all these places have stretch receptors. The effectors are at the carotid sympathetic nervous system, at the macula densa, renin, angiotensin, and then aldosterone, and at the atria, it's natriuretic peptide. And ADH, or antidiuretic hormone or vasopressin, is activated as a large ditch effort for the organism to survive. When we look at what effects are mediated through these effectors, what we find is that there is vasoconstriction, which angiotensin will provide, as well as the sympathetic nervous system will provide. But those are short-term effects on the blood pressure as well as for volume regulation. While the long-term effect is through sodium retention, which is through aldosterone, or decrease in the natriuresis by decreasing the natriuretic peptides. So when we look at how this goes on or how it plays, what we have is that if there is any increase in ECF volume, the renin decreases, the atrial natriuretic peptide will increase, and this will cause an increase in the sodium excretion, and then the ECF volume comes back to normal. While if the ECF volume has decreased, then it will cause a renin-angiotensin aldosterone activation. The ANP will decrease, and this will cause sodium retention. And with sodium retention, there will be ECF volume increase, and that will lead to replenishment of the ECF volume. In comparison, when we contrast, when we talk about plasma osmolarity and plasma osmolarity regulation, one of the things that we need to keep in mind is that osmolarity and tonicity, when we talk about plasma tonicity, it is the effective plasma osmolarity, and the effective osmoles include sodium, but there are some ineffective osmoles like urea and ethanol, which freely distribute across the cell membrane and hence do not cause the osmoreceptors or any other cells to shrink or expand, and which is how the osmoreceptors actually respond to the osmolarity and actually sense osmolarity. It is by a change in the size of the osmoreceptor based on the tonicity that is surrounding them. So as we talked before, the ineffective osmoles are urea and ethanol. In chronic kidney disease patients, the plasma osmolarity may be high because of urea, but the tonicity is normal. However, there is a situation in which urea can become an effective osmole, and that is when during dialysis, we dialyze someone, and if they have a urea of, let's say, 100, by the end of dialysis, it becomes 35. And that quick decrease in urea, the cells, whether it's in the brain or the rest of the body, the cells cannot equilibrate the urea that fast. And so in that situation, the blood will have less urea, the cells will have more urea, and water will go inside the cells and can cause cerebral edema and dialysis disequilibrium syndrome. So how does the body regulate osmolarity? So again, if there is an increase in water intake, the plasma tonicity will decrease. This decrease is sensed by the hypothalamus, by the osmoreceptors, and with that, the ADH will be decreased or stopped depending on the severity of hyponatremia and hypoosmolarity. And then with no ADH present, a dilute urine is passed. In contrast, if there is water loss, the plasma tonicity will increase. It will cause the activation of thirst and ADH. And with the ADH, there will be a concentrated urine that will be excreted. And with the increased thirst, water will be taken in, and that will cause replenishment of the water. So how is this osmolarity and hyperosmolar or concentrated urine produced? The glomerular filtrate is actually isoosmolar with a osmolarity of 300, which is at the starting. And then there is the counter current that happens in the loop of Henle, and that is dictated predominantly by the sodium potassium 2 chloride channels, which reabsorb sodium and potassium in the thick ascending limb, and this thick ascending limb is actually impermeable to water. So the counter current will then concentrate the osmolarity to a maximum of 1200 at the tip of the loop of Henle. With this impermeable thick ascending limb, as sodium is reabsorbed, the concentration of the fluid inside the tubule decreases and goes down as low as 50 to 100. This is then maintained through the distal convoluted tubule and reaches the late distal convoluted tubule as well as the collecting duct. In these parts, there is water permeability, but that is dependent on the ADH. And if ADH is present, then aquaporins get placed in the luminal surface and allow water to be reabsorbed. and depending on the amount of ADH present, it can increase the osmolarity all the way up to 1200. If there is no ADH, then the dilute urine, which is 100, gets passed all the way along and comes out in the urine. So just to look at how ADH works, the ADH will work through the V2 receptor, which is on the top panel here, and will activate the V2 receptor. The V2 receptor will then activate the adenylyl cyclase and cause cyclic AMP, which will then cause the activation of the aquaporin to integrate from the vesicles into the luminal surface of the membrane and cause water reabsorption. This is dictated through the ADH and will depend on the amount of ADH present. So one of the amazing things about the kidney is that it has a huge capacity. The minimum urine osmolarity is between 50 to 100. The maximum is up to 1200. Normal solute intake is about 600 to 700 milliosms. And so the urine volume can range with a fully concentrated urine can go down as low as 500 ml and to a maximum dilute urine to 12 to 14 liters. So again, because the kidney has a capacity of 12 to 14 liters, what it means is that hyponatremia, which is due to water retention, should not occur unless there is impaired water excretion with rare exceptions. And that ADH is the main defense against hyponatremia. In contrast, when we look at hypernatremia, thirst is the main defense against that. So in this figure, on the y-axis is the ADH hormone, and on the x-axis is the plasma osmolarity. And as you see, between 270 to 280, ADH is flat because you're in the hypoosmolar part. And once you go beyond 280, ADH starts increasing, and thirst kicks in somewhere around 290 to 295 milliosms. With ADH, which is completely suppressed, the urine osmolarity will be less than 100 milliosms per liter. And with thirst, the key concept is that thirst is a very potent stimulator, and even if there is no ADH, thirst will prevent hypernatremia. So if you look at patients who have central diabetes insipidus and do not have any ADH at all, they will not develop hypernatremia even if they're excreting 10 liters per day, because the thirst will maintain them and push them to drink the 10 liters as well. The corollary from that is that symptomatic hypernatremia will not develop in any patient with an intact thirst mechanism and access to water. So as long as someone has a thirst and can get his hands on water, they will not develop hypernatremia. So hypernatremia only develops in patients who are either intubated or comatose or are limited by the doctors or cannot get their hands on the water, because thirst would be active when they develop hypernatremia, and if they could get their hands on the water, they would drink themselves down and bring their hyperosmolarity and hypernatremia back to normal. So another concept to look at is the wide range of osmolarity, and that dictates the range of urine outputs as well. And with ADH, the kidney will alter the amount of urine that is being produced based on the water intake. So as the water intake increases, ADH goes down and the urine output goes up. If you decrease your water intake, the urine output will go down by concentrating the urine with an increase in ADH. So the kidney, with the help of ADH, adjusts the amount of urine by osmolarity and matches the intake to the output. So if you look at the graph here, it will also depend on the solute excretion. If you have a normal solute excretion of about 600 osms, which will be based on how much your intake is, and you maximally concentrate your urine because you only drank 500 ml, then the kidney will put out 500 ml. If you drink 10 liters of fluid, then the ADH will shut down and be able to keep up with that with 600 osms as well. The corollary on that is that in a fixed ADH state, where whether it is diabetes insipidus or SIADH, where the ADH is either non-existent or the ADH fixes your urine osmolarity at 600, then the urine volume will be dictated by the amount of solute that you drink. So for example, if you have an SIADH patient with a urine osm of 600 and your intake is 600, your urine output is going to be 1 liter. So if you want to change someone with SIADH and want to increase their urine output, you're going to need to increase their protein intake or their salt intake. And so they go from 600 osms to, let's say, 900 osms. And even if the urine osmolarity is now fixed at 600, they're now going to be able to excrete 1.5 liters. In contrast, if you have someone with diabetes insipidus, and let's say his urine osmolarity is fixed at 100, so with 600 osm intake, he is going to put out 6 liters. If you decrease his solute intake from 600 to 400 by decreasing his salt intake, now he'll only put out 4 liters because the urine osmolarity is fixed at 100 and he is taking in only 400 osms in a day. So now coming back to the concept of the sodium content versus the sodium concentration. This is, I think, the key take home from my talk, that the sodium content is and the amount of sodium in the body dictates the extracellular fluid volume, while the sodium concentration is reflected in the osmolarity and actually reflects the water status, which means that hypernatremia are water problems. So let's go over and revise how osmolar regulation happens. So osmolarity, which is through sodium concentration, is sensed as plasma osmolarity by the hypothalamic osm receptors. The effectors from these are ADH and thirst. What gets affected is water excretion and water intake, and the disorders of this are hypernatremia. So the body is sensing the osmolarity, and the way it affects it is through water intake and water excretion. So hypernatremia are being regulated by the body through water, and the problems are due to water excess, which is hyponatremia, or water deficit, which is hypernatremia. So I would suggest and want people to think of hyponatremia as a water excess problem and hypernatremia as a water deficit problem. In comparison, volume regulation, which is the total sodium in the body, is sensed as effective circulating volume by the carotid sinus, afferent arteriole, and the atria. And the effectors are renin-angiotensin aldosterone, the ANP, ADH, which is the last stitch, and the sympathetic system. And again, leaving aside the short-term impact of vasoconstriction, the long-term impact is through urinary sodium excretion or retention. And the problems from volume regulation or total sodium are either volume depletion, which means too little sodium in the body, or edema, volume overload, which means too much sodium in the body. So again, when you look at how the body regulates them, they are actually completely independent, and there is almost no overlap in how the body regulates volume and how the body regulates osmolarity. They are completely separate systems. The body treats them separately, and we, when we evaluate patients, should also evaluate these two entities separately. Patients can have a combination, so they can be any combination. So you can have hyponatremia with volume depletion, hyponatremia with edema, hypernatremia with volume depletion, and hypernatremia with edema. And so we should think of the problem separately and see if the solution is the same, which could be the case in someone who has hyponatremia and volume depletion. You give them normal saline, their volume depletion as well as hyponatremia may improve, but it may need different interventions based on the etiology that is causing the independent issues. So now let's talk about the only overlap that there is, which is ADH, which is activated by both osmolarity as well as volume. So these are classic, this is one of the classic studies and papers that were done by Robertson in 1970s. And this is kind of a summary slide from it, which is in all the physiology books. So on the y-axis is the ADH level, and on the x-axis is the percent change in both either osmolarity through osmotic isobol changes, or volume depletion, which is with the full dots, and then the white dots or white circles is the osmolarity changes. As you can see, even small changes or minor changes in osmolarity within the 0 to 1% and 2% range will cause a linear and significant rise in ADH. In comparison, when you look at volume for the first 5 to 7%, you can continue to lose volume, but there will be no increase in ADH. ADH only goes up once you lose about 7 to 10% of volume, and then ADH will kick in in an exponential fashion. So this is kind of the last ditch effort by the body to save the organism during any kind of critical illness where the body feels that there has been a significant volume loss, whether it's by GI bleed or diarrhea or any other kind of volume loss, where the body feels that this is now at an extent where it will be life-threatening, and so ADH gets revved up as at that point. Of note, the renin-angio-aldosterone system would be long active long before ADH gets revved up. So any patient, whether it is a true volume depletion or effective volume depletion like a cirrhotic or a CHF, by the time ADH gets activated, the renin-angio-aldo system would have been activated long before. So all patients in whom hyponatremia or ADH is activated due to volume loss will have a urine sodium which is less than 20, because their renin angio and aldo system has been revved up and has been activated long before the ADH actually kicks in. So now let's come back to the original patient that we started off with, the 60-year-old with 80 kg with heart failure and pedal edema and pulmonary edema, who's been intubated and has now developed hypernatremia. So how would you treat him? So to come back and put it together with the diagnosis that we have, so he has two issues. One is he has edema and volume overload, which is very high or excess of sodium in the body, or the total amount of sodium is high. And then he has hypernatremia, which, as we talked, is a water problem, and he has a water deficit. So he has two separate problems: too much sodium in his body and too little water in his body. So the way we come back to this is that hypernatremia is too much water, and edema is too much sodium. Hypernatremia is too little water or water deficit, and edema or volume overload is too much sodium. So the way to treat it is to give him the diuretics, so he continues to lose sodium through his body and the extracellular fluid volume continues to contract. And we give him free water, which is to assess and quantify how much we should give. We need to give him the current volume, the current free water losses, and that for a diuretic urine or a Lasix urine, usually it is half normal saline. And so we can think of it as we think of half normal saline, like we talked in the example when we are giving it IV. So half of it is normal saline and half of it is plain water. And so we have to replace the plain water that he's losing, which would be 1.8 liters. In addition, there will be insensible losses about 500 ml. and then we give some part of the deficit, which is going to be about 1.2 liters. And the total will come out to be about 3.5 liters. So we can give him through the Ryle's tube or through D5 water at 150 ml per hour. And the extracellular volume will continue to contract even though the input output will show that he is net even and the weight hasn't changed. So this is something which, especially with cardiologists, will be a constant battle, that the input output is even, and so they might push that we would want it to be negative in the setting of this edema and heart failure. So just to kind of, for anyone who still isn't convinced, the plain water that we give, 60% of that will go inside the cell. So just to kind of show that, going back to how water is distributed, so for this 80 kg person, I'm taking him to be 70 kgs with 10 liters of extra volume. So the 42 liters was his original, and then 10 liters is extra. And all of this 10 liters is going to be in the extracellular fluid compartment, which is where all edema lies, is in the interstitium and the intravascular compartment. So his intracellular fluid is still 25 liters. And then the extracellular fluid is the 17 liters plus the 10 liters of extra edema. So now after 2 days of diuretics and 7.2 liters negative and a sodium of 153, so what has happened to him is that he has lost weight and he's now at 74 kgs. And half of it is going to be normal saline that has come out, and that will come out directly from the extracellular fluid compartment, which will be going down from 10 liters to 6.4. So 3.6 liters has been lost. And the remaining 3.6 liters is plain water that he's lost. And that will come out from 60% from the intracellular compartment and then 40% from the extracellular compartment. Now, when we give him diuretics and the free water, even though his weight remains same, the 3.6 liters that he's lost, half of it is like normal saline and will come out, 1.8 liters will come out from the extra edema that he has. And so his edema compartment goes down from 6.4 to 4.8. But the plain water that we give will go into, again, the same ratio, 60% into the intracellular compartment and 40% into the extracellular compartment. And with that, his weight is remaining same, but his extracellular fluid volume has gone down from 22 liters to 20.7 liters. So he is still losing edema, and his extracellular fluid volume is going down, even though his weight remains stable. So I hope I've been able to convince you that for someone with hypernatremia in the setting of edema, we should continue to give diuretics and give them free water. So now I'll talk a little bit about steady state, which I think is one of the key concepts for not just fluid and electrolytes, but also in how body maintains its homeostasis. So this is a picture from, again, one of the classic sodium balance studies that were conducted before. And on the y-axis in the bottom is the sodium intake that the person has, and on the top is the weight of the person. And these volunteers started off with 10 millimoles of sodium intake every day, 10 milliequivalents of sodium every day. And after a few days, they increased it to 150 milliequivalents every day. So if you look at what they start off with, the sodium excretion forces and the sodium retention forces are in balance, and the person maintains their weight for the first 3 days. Then when they increase their sodium intake to 150 millimoles, what happens is that with the increase in their sodium intake, there will be an increase in their extracellular fluid volume. As this extracellular fluid volume increases, the sodium retention forces will go down, So the renin, angiotensin, aldosterone system will shut off, and the ANP, which is the sodium excretion forces, will increase, and so the sodium excretion will increase as well. However, this excretion will take a few days to match the actual increase in intake, which is over the next 3 to 4 days, and then towards the end, the excretion and intake will match again. However, this is at an increased weight, or which is an increased extracellular fluid volume. So the person's weight has gone from 70 kgs to 71 kgs, and this extracellular fluid volume that is increased is what is driving the excretion of sodium. And now the person is back at steady state, with both the excretion and intake matching, and the sodium intake is also 150 milliequivalents, and the excretion is also 150 milliequivalents. When this person now stops taking that sodium and goes back to his old 10 millimole intake or 10 milliequivalent intake, the sodium excretion will continue for a few days, and the person will lose the extra sodium that he got, and the retention forces will now start going back up, and then they will come back into balance, and the weight will also go back down from 71 to 70. So again, this is key, that ultimately, even if you make a big change in sodium intake, you do get back to a steady state with some increase in extracellular fluid volume. Um, on the reverse, or on the flip side, if you look at sodium loss with a thiazide diuretic, so this is a study in which patients were given thiazides, and then their sodium excretion and sodium balance was measured. In the gray is the sodium excretion and sodium balance, and in the red is the potassium balance. So if you see, for the first 3 days there is a sodium loss, and then after that there is no further sodium loss. And for potassium, the potassium loss is for the first 7 days. After that, there is no further potassium loss. So what this means is that, again, the patient comes back into a steady state after losing sodium and potassium for the first 5 to 7 days, and they get back into a steady state, having lost some sodium, which will be associated with some reduction in the extracellular fluid volume, which is how it controls blood pressure, by this reduction in the extracellular fluid volume. What this also means is that any hyponatremia or hypokalemia that is going to develop will happen by the end of 1 week. If at the end of 1 week someone on a thiazide, so a specific dose of a thiazide diuretic, has not developed hyponatremia, hypokalemia, they will not develop it in the future. If they do develop it beyond that period of time, then there is another cause, or something different has happened, and that should be investigated, because the thiazide diuretic should not cause something after the steady state has been achieved. Similarly, this is a study in which there is urinary sodium excretion on the y-axis and time in the x-axis, and they're looking at loop diuretics, which is furosemide, in a continuous bolus, which is the solid line, and a bolus dosing, which is the dotted line. And what they find is that the total amount of sodium excreted for the same dose is higher with a continuous infusion versus bolus dosing. But what I want to focus on is the effect of what happens when you give the second dose. So when you start, the sodium excretion and retention forces are in balance and you're at steady state. When you give the furosemide, the first dose injection, what happens is that you've now lost volume, and the sodium retention forces take an increase while the excretion forces go down. With that, what happens is when you give the second dose, the retention forces are much larger, and so the effect of the second dose of Lasix is now much lower compared to the first dose. And this shows that, again, over time, as you keep giving these doses of Lasix, whether it's oral diuretics or IV diuretics, at some point you are going to come back into steady state for a specific dose of furosemide or torsemide as well. This is not just limited to sodium and water. This is also applicable to potassium. So this is from a paper in 1990 where 6 volunteers who were originally on control period, 100 millimoles of sodium and 100 millimoles of potassium during the control period, then increased their potassium intake to 400 millimoles of potassium, something which I'm not sure anyone ever will get to. And what it shows is that in the control period, the potassium excretion was 70 to 80. During the first 3 days, the potassium excretion increases and reaches by 2 to 3 days and then maintains it by day 20 to almost 400 millimoles, which is what their intake is. And there will be some other non-urinary excretion as well. So this is now steady state where the urinary potassium excretion is now matching their intake by day 20, but is very close to it by day 3 as well. And when they stop, which is the deadaptation phase, very quickly within 24 to 48 hours, they lose the extra potassium and they're back into steady state with a urine potassium that is excreting between 70 to 80 millimoles every day. The important thing to note is that when you see what their serum potassium do as well, at control period, they started off with a potassium of 3.75, and even at a peak, their potassium increases to 4.7, but at baseline, when they go back into steady state, the potassium is only 4.17 and 4.2. So with an increase in potassium that goes from 100 millimoles to 400 millimoles, the actual increase in serum potassium is only small, from 3.75 to 4.1 or 4.2. And then when they stop their potassium, they go back to their previous baseline. When you look at aldosterone as well, the aldosterone increases all the way up to 1,000 from 400. And by the time you reach steady state, it is very close to its previous baseline, just slightly higher. And this slight increase in potassium, serum potassium, as well as slight increase in aldosterone, is enough for the kidney and for the body to excrete 400 millimoles of potassium every day. So what this means is that you cannot load yourself to hyperkalemia. No matter how much potassium you eat, the body with adaptation will be able to excrete it. And so hyperkalemia will only develop with impaired excretion, and you cannot eat yourself to hyperkalemia if excretion is normal. So this is about steady state. And I would like to thank Dr. Burton Rose, who has been one of whose examples as well as whose teaching has been used a lot in this talk, and Dr. Ajay Kher, who's been my role model and mentor as well as father, and Dr. Jha for giving me the opportunity for this talk as well as the series as well. And now I would be happy to take any questions about this. Thank you.
Thank you, Ajay, for this wonderful talk and fascinating explanation of water and sodium physiology. I hope that people have been able to understand the somewhat difficult concept of differentiating in a way the body fluid compartments into separate independent determine the sodium concentration and the extracellular fluid volume. I'm sure that this is not easy for everyone, and what I would request people is to come back to this, because we'll post this talk on YouTube, so you can go over again and listen to clarify some of the concepts. So as usual, we will start with some questions, but before we do that, I would like to point out two firsts for this webinar. One is that we have the highest ever number of attendees for this webinar, which is fantastic, which indicates people's interest in the topic, proving that physiology remains fascinating to a large number of pathologists. And the second is, again, the attentiveness of those who have been listening to this talk, is that questions started coming while you were speaking on those specific points that you were talking, Ajay. So we will do that in our usual way. So we have a few hands raised. So I'm going to unmute the people whose hands have been raised so that they can ask questions directly. After which I will read out the questions which have come on the chat pane. So the first person I'm going to unmute is Dr. Rajiv Sinha, who perhaps has a question. So Dr. Sinha, please go ahead.
Hello, can you hear me?
Yeah.
Yes, go ahead.
Hi, that was a very good presentation. I think I joined a bit late. So I have just one small question, that furosemide, does it clear sodium, or does it only clear salt-free water?
Sorry, does it clear sodium or water?
Yeah,
Is that
like
the question?
does it only clear salt-free water, or does it also clear along with that sodium? Because when we are giving furosemide in say nephrotic syndrome, we are should we be worried about hyponatremia or not? Because I have heard the different school of thoughts. Someone saying that as a furosemide only clears salt-free water, you should not be having hyponatremia. And there are other school of thoughts as well. As in my own practice, I have seen furosemide causing hyponatremia.
Okay. So thank you for the question. So when furosemide acts, what it does is it will block the sodium potassium 2 chloride channel. There will be a sodium loss, but with the sodium loss, usually the osmolarity of the urine will be close to isoosmolar, somewhere between 200 to 400 osms, and the sodium content will be somewhere around 75. So it's like a half normal saline fluid. So what it does is that it will cause sodium loss. With that, there will be some water loss as well. The development of hyponatremia is, again, it is a water problem. So if you have with free water, there will be free water loss that will happen in the setting of giving Lasix to someone. So that free water loss, unless it is replenished, will actually lead to hypernatremia, which is what my question and my example of the case was, that someone is on furosemide will cause and tend to cause hypernatremia. However, if your person or patient has an high ADH state, which is from, in this situation, nephrotic syndrome, and that high ADH is driving, due to effective volume depletion, the osmolarity to, let's say, 900, then Lasix or furosemide will bring it down, because it is knocking off the counter current as well. It will drop it down from 900 to maybe 400, 500. And if the intake of that patient is hypoosmolar to that, then they can develop hyponatremia in that setup. So this is dependent. So development of hyponatremia is actually dependent on what is coming in and what is going out. What is in the body doesn't matter. So if his intake of solute as well as water is hypoosmolar to what the urine is putting out, and you can also look at it as an electrolyte free concept, in which case that would be a different way of looking at it, and you can assess that as well. But the urine will have salt and sodium in it, because Lasix will excrete sodium with it, and so the tendency is for hypernatremia to happen. But if your intake is very poor, with no protein and no salt and only water, then that patient can develop hyponatremia with furosemide as well, especially in settings with high ADH states. So I hope that answers your question.
Thank
Do
you.
you have any follow-up
It
questions?
does. Yeah, it does. Thanks.
Okay, thanks. So the next question is from Dr. Abira Mansoor. So I'm going to unmute you, Dr. Abira Mansoor. Go ahead and ask your question. I think there is some problem with Dr. Mansoor's audio. So we will go ahead to the next one, which is Dr. Venkatesh Rajkumar. So Venki, you have any question? Go ahead.
Thanks, Dr. And thanks, Dr. Ajay. That's a nice presentation. So my question is about the familiar scenario we are discussing, hypernatremia in an edematous patient, particularly somebody with a cardiac failure, and you are describing like how we can use diuretics along with free water. My question is, free water, what do you mean by that? Just RT water, or you can as well give a dextrose parenterally? Because giving something parenterally in somebody who's got a cardiac failure, is it the same as giving RT free water?
Yes, D5, the dextrose that you give is going to get taken up by the cells. It's going to be catabolized, so the dextrose is gone after a few hours. So the D5 water is exactly the same as giving it plain water through RT. So if you have an RT in place, you can give it plain water. If you have no RT in place, or you can't give it through the RT, or the person can't drink, then you can give it as dextrose. So it's exactly the same and shouldn't make any difference whether you give it through the RT or through the D5.
Yeah, even in somebody who's got cardiac failure with a compromised LV.
Absolutely. The D5 is 60% of that is going to go inside the cell. It is not going to be in the intravascular compartment. It is not going to be in the extracellular fluid compartment. 60% of it is inside the cell, and it will not increase the edema. It will not increase the heart failure.
Okay. Yeah. Thanks, Dr. Ajay, and thanks, Dr. Jha.
As long as you continue it with diuretics, so you want to keep losing the sodium as well.
Yeah.
Thanks, Ajay. So I'm going to check once again if Dr. Abira Mansoor is back with audio. Looks like not. Next, we have Dr. Srinivasan. So I'm going to unmute you. Dr. Srinivasan, go ahead. Dr. Srinivasan, go ahead and ask your question. I guess Dr. Srinivasan is not able to ask. So I will now go on to the next one, Dr. Krishna Sahu. Dr. Sahu, I guess people are having questions with their audio, problems with their audios, but people have actually sent in written questions. So I'm going to now start one by one. There are lots of questions already. So the first question is from Dr. Manan Doshi, who asks, how does plasma light distribute in the body?
So plasma light has a sodium of about 132. So it's going to be very close to normal saline. There is some amount of hypoosmolarity there. So some of it, so I would treat it like out of 150, 132. So like whatever the math comes out of that, like 80% normal saline and 10% plain water. And if you look at any of the studies, especially the new studies that have come out with plasma light, there is some hyponatremia that has happened because in those plasma light studies versus normal saline. And that is because, which is whether it's plasma light or lactated ringer, the sodium is lower than normal saline, and so there is some hyponatremia that happens in those situations. But I would treat it like 80 or 85%, whatever 132 by 150 comes out as. Let me see if I can do that quickly. So it's going to be 85% or 86% normal saline, and then 15% plain water.
Yeah, thanks, Ajay. So we have the next question from Dr. Ajit Singh Narula, who always likes to bowl a googly, but looks like he's bowling a straight ball here. He asks, please give a real life situation where there is isovolemic where there is isovolemic osmotic increase other than iatrogenic?
Isovolemic osmotic, so hypernatremia, which is isovolemic. Is that the question?
Yeah, which is not iatrogenic. Yeah.
Hypernatremia with, so hypernatremia by itself, because thirst is going to be active, if thirst is present and the person can get his hands on water, there is no reason why anyone ever will get hypernatremic. So unless someone has a problem with their thirst mechanism, so if someone is hypernatremic, let's say 150, and is walkie-talkie, then the only way that can happen and can get his hands on water is if his thirst mechanism is not working. So there is something wrong with the hypothalamus and the thirst center. That is the only way someone walkie-talkie with able to get his hands on water is not drinking. The only other way would be like Ramzan, where someone is voluntarily putting
That's
him.
a
Hello? Yeah. So if, yeah. So if in Ramzan or other kind of fasting mode, someone isn't drinking water, they might get to hypernatremia also. Hello?
That's a very important concept, and I would like to repeat it by saying that hypernatremia is going to be extremely unusual when someone is willing and able to have access to water. So that's a very important concept for everyone to remember. So if you are talking to someone and if someone is thirsty, that is a direct indicator that something is going on there. So the next question is from Dr. Lavi Gaur, who perhaps is referring to the point where you were describing intermittent dosing of furosemide, and she asks, does this also imply that with the BD dosing of diuretic, the second dose needs to be higher than the first one?
So there is a little difference when we are treating patients who have heart failure versus this study in which this was in stable chronic kidney disease patients. So when someone has heart failure or nephrotic syndrome or cirrhosis, the difference is that there is a edema compartment that can equilibrate to the intravascular compartment, and that edema may be a source of continuous replenishment going on for many days. So this study was in patients with stable chronic kidney disease, and when you are in that kind of situation, what will happen is that over time you're going to reach a steady state. So let me use furosemide, and in this situation the second dose is going to have a lower and lower effect. And it's not just about the second dose, it's about the second day, about the third day, about the fourth day. By the fourth or fifth day, you're probably going to be in steady state. So let's say you have a chronic kidney disease patients and you're putting them on oral furosemide and you're sending them home. At some point, they're not going to lose weight anymore. So at 3 days or 4 days or 7 days, they will be in steady state. And after that, there is not going to be any further loss at that dose of furosemide. So if you want more weight loss, you're going to need to increase the dose. But it might be enough to keep them in balance, and that might be what you need to achieve as well. So it depends on what your weight target is, what your volume target is, what your blood pressure target is, and that will dictate whether you want to increase your dose of furosemide or whether you want to keep it the same.
Thanks, Ajay. So next question is from Professor Natarajan Gopalakrishnan from Chennai. Dr. Gopalakrishnan, please go ahead.
Good evening. That was a wonderful presentation. Am I audible?
Yes.
Yes.
Hello.
Yes.
Yeah. The two things. One comment I would like to make is that somebody asked the real-time clinical scenario of euvolemic hypernatremia. We do come across very severe hypernatremia in brain-dead individuals, and very often we find it difficult, and we find it as a kind of a deterrent to go ahead with apnea test to confirm brain death. Here, the mechanism is the hypothalamic dysfunction and leading on to a lack of ADH.
No, someone who is brain dead is not getting, he has no control over what he does. The control is in your hands. So he needs more free water. And unfortunately, many times we as physicians are hesitant to give free water through the RT. So if he's developed hypernatremia, it's on us, because his control over water intake is not his, it's us. So his hypernatremia is all us. So I would beg to differ and say that this is the amount of free water that his body needs is not being provided by us.
Dr. Gopalakrishnan, did you have any follow-up question or a second question? Okay, I guess not. So we'll go back to the list. And so we have now a next question.
Part 3, that is true. That is no thirst and yeah.
Yeah, no, go ahead.
Second question is that can you just comment on how do you go about in management of chronic hyponatremia, which is
Sorry, you were getting cut. So chronic hyponatremia?
So what Ajay, I will say is that Dr. Gopalakrishnan, Dr. Kher will address specific issues related to hyponatremia in a subsequent webinar. So today was just the basic physiology discussion. So if it's all right, perhaps we'll leave this question to a subsequent webinar, right?
Sure.
Okay, so next question from Dr. Dipankar Sarkar, who asks, how does urea loading help in hyponatremia? Is it practical?
sure.
Okay, so this comes back to, let me come back here to see this one. So what is happening when you give someone who has, let's say, SIADH? So as I was using the example in this, the SIADH, let's say someone has a urine osmolarity of 600, and this is now fixed. So every day his urine osm, 24 hours a day, 7 days in a week, is going to be 600. So normal solute intake is 600. So if he now is taking 600 osms a day, and his urine osmolarity is 600 osms per liter, he can only excrete 1 liter a day. So if he drinks 2 liters, he is positive 1 liter every day, and so his hyponatremia is going to continue to get worse. So if we fix him at 1 liter, he's going to maintain his sodium at whatever it is. So if he's, let's say, at 120, and now serum sodium is 120, and he is taking 600 osms, drinking 1 liter, and his urine output is 1 liter, you're not going to make any headway in improving his serum sodium. So the only way you can increase his serum sodium is by either increasing his osmolar intake, which can be by urea, it can be by sodium, it can be by protein intake, whichever mechanism you want. And so now if he increases his osmolar intake to 900 osms and the excretion is still fixed at 600, then he's going to put out 1.5 liters. You restrict his free water to 1 liter and he's negative by half a liter every day, and his serum sodium continues to improve every day. The other option would be to cut down his urine osmolarity. So you bring his urine osmolarity down from 600 to 300. The way to do that is either knock out the ADH, if you have a mechanism of doing that, which would be like an SSRI, where you can get rid of the SSRI, or you put him on Lasix or furosemide, which will knock the counter current out and bring his osmolarity down to close to isoosmolar around 300. And so that will allow the increase in the urine output for the same osmolar intake and allow the serum sodium to improve.
Okay, so The next question is from Dr. Krishna Sahu, who first of all compliments you on the presentation, and then he has actually two questions. So the first one is, does the distribution pattern of administered saline that you described hold good in states of increased capillary permeability?
So in the setting of increased capillary permeability, the permeability from the capillary doesn't change the presence of sodium potassium ATPase. So the intracellular to extracellular distribution will remain the same. The difference may be in the intravascular to interstitial compartment difference. And so that actually I didn't talk about and is actually part of sodium water balance. Sorry, I've gone through. Is actually part of the sodium water balance and will dictate based on, let me put this, and is dictated by the local hydrostatic pressures, the oncotic pressure, and the capillary permeability. So the difference will be that instead of staying in the intravascular compartment, now some of it is going to be in the interstitial compartment, and this ratio of 3/4, 1/4 may not be applicable in that situation, where if you give 1 liter of normal saline, 3/4 of it is going to go into the interstitium and 1/4 is going to stay in the plasma. So instead of that, that may be no longer true, and some of it will leak into the interstitial fluid as well.
Yep. The second question Dr. Sahu has is, if we administer bolus doses of Lasix more frequently, such as every 4 hours, will it still be less effective than infusion?
That is what the studies have shown. It will be better than twice daily dosing, but it will still be lower. And let me come back to that picture. And the reason is that Lasix works on threshold. And the reason that, come back to this. So Lasix works on a threshold. So let's say that the threshold of Lasix is 20 milligrams. So if you give them 10 milligram boluses every 4 hours or every 6 hours, you've given them 4 placebos and there isn't going to be any response at all. When you give them 40 milligram boluses, you are going to get 2 responses, which will be close to what we are seeing here. But the drip, once you give them, and whenever you start a drip, you should give them a bolus up front, because otherwise to reach above the threshold will take time. So you start with the bolus, put them on a drip, and that will maintain their Lasix concentration above the threshold, giving you constant sodium excretion. And that is why the area under the curve with a drip is higher than bolus dosing.
Yep. And also, just as a follow-up point to that, is that all the time duration where the renal tubules are not exposed to optimal Lasix concentrations, the tubules are actually going to absorb salt even more avidly than they were during the time when they were getting the sodium. So that's also an important point to make.
Absolutely, absolutely.
So the next point is, next question is from Dr. Sanjeev Nair, who is following up on Dr. Rajiv Sinha's question, and and Ajay, where you gave the example of using Lasix in nephrotic syndrome. So Dr. Nair asks, when we prescribe Lasix in nephrotic syndrome, we'd have to advise the patient to maintain or improve protein and salt intake to prevent Lasix-induced hyponatremia?
I would not say salt intake, because as we said, someone who has nephrotic syndrome has extracellular fluid expansion, which means that they have too much sodium in their body. So we should not be advising them high sodium diet. We should be advising them limited fluid intake so that they don't develop hyponatremia if that is a concern, and a high protein intake so that there is enough solute for the body if they're at risk for developing hyponatremia. And I usually encourage all patients who have hyponatremia or at risk of hyponatremia to take high protein intake. Most of these patients are not eating well, they're not feeling well, and so usually I have to give them some protein supplements And so on my hyponatremia treatments, protein supplements are usually routine.
Thanks. So the next question again from Dr. Dipankar Sarkar, who wants to know this time, what will be the situation in your patient, which is heart failure with hypernatremia and volume overload, if the patient has renal failure as well?
So in that situation, if he has renal failure, his response to Lasix will be poorer, and then his hypernatremia would not be as much because he would have less free water clearance. But the treatment would still be the same. You would give them higher and higher doses of furosemide, and if he develops hypernatremia, you would give him free water as well.
Right. So the next question is from Dr. Prakash Javandia, who wants to know, do we need to correct asymptomatic chronic hypervolemic hyponatremia as you see in liver failure?
So I do think if it is possible, we should fix it. But the question is mostly how, and how easy it is. And so majority of the time, as long as I can do it with furosemide and some aldactone, that will help control their edema as well as increasing their protein intake, I will push them. The question then goes on to, if they continue, what is the role for, I think, tolvaptan? And the ultimate issue with hyponatremia is that even though it is associated with mortality, there is no study so far that has shown that treating the hyponatremia improves mortality or improves any other morbidity other than improving the number. So at present, usually I will not put patients on tolvaptan, because ultimately, as soon as you stop the tolvaptan in all those studies, the sodium goes back to where it was before. So, and there is no morbidity or mortality benefit by just giving them tolvaptan. So usually what I will do is, they need edema reduction because they have volume overload. So I will focus on furosemide and aldactone to try and improve their edema. And I will try and improve their nutritional status and give them protein supplements and try and improve and limit their free water to try and correct it as best I can. But usually I will not put them on tolvaptan, if that was what the question was.
Yep. So the first thing to say is that that question was not from Dr. Pankaj, it was from Dr. Mahesh Prasad. And now I read out Dr. Pankaj Javandia's question. He wants to know, so we have a lot of questions on repeat Lasix dosing. So he says, can we say that Lasix, people who receive repeated dose of Lasix develop tachyphylaxis after 72 to 96 hours?
So again, I wouldn't say that by that mechanism. And again, I would want to caution that people who have severe edema, whether it is nephrotic syndrome, cirrhosis, or heart failure, have a capacity to refill their intravascular as well as compartment. So these studies, which are steady state studies and actually rely on and actually are applicable to people who are stable diseases, so stable kidney disease or normal patients with hypertension. So in those situations, you will reach a steady state very quickly, within 3 to 5 days. Someone who has heart failure and has massive volume overload may respond to the same dose for a prolonged period of time, because he will keep refilling his intravascular compartment from which the Lasix is going to work. So I'm not sure that I would say that these diuretics are now getting tachyphylaxis, and especially tachyphylaxis would not be the right term anyways, because the Lasix can still bind to the sodium potassium channel and would still increase the sodium excretion compared to if you don't give it, in which case the sodium reabsorption will happen. So I wouldn't use tachyphylaxis in that regard. But the response may get lower, especially in stable disease where you are going to reach a steady state. In heart failure and cirrhosis and nephrotic syndrome, I'm not sure whether there are good studies to show when you reach steady state and how you reach the steady state in those situations.
Okay, so next we have a raised hand from Dr. Saivani Yelampalli. So I'm going to unmute you, Dr. Yelampalli. Would you like to ask your question? I think you have muted yourself as well, so you might have to unmute yourself from your side if you want to ask a question. Okay, so I'll read out the next question, which is again from Dr. Sahu. Do you think aldactone might worsen hyponatremia by antagonizing aldosterone?
So when we look at the only predominant effect from aldosterone is going to be on the potassium, and so with aldosterone you will have some increase in potassium, and potassium actually works the same as sodium. So I was hoping to use it for my next talk in hyponatremia. If you give potassium to someone, it is like giving sodium. And so the same thing would be true when you have aldosterone, where the potassium will increase. So that may actually help a little with hyponatremia with the increase in potassium. But I'm not sure there is any other mechanism by which it would make things worse, because it's acting at the distal convoluted collecting duct and collecting tubule. And the ADH mechanism is separate. So I don't think it would make any difference from that regard.
Okay, thanks. So looks like, oh, we have one more question, which I think we will leave for some other webinar, which again, Dr. Sahu continues to follow up. He asks, aldosterone is known to retain sodium. He's trying to argue his point.
So there is, so I actually did not put in hyperaldosteronism. There is an escape that happens. I didn't put the slides or the balance studies that have been done with hyperaldosteronism. And so with aldosterone, when you have hyperaldosteronism, you generally don't see patients with edema. And the reason you don't see that is because you have these sodium excretion and retention forces. And even though you have the aldosterone that goes up, the other sodium excretion forces with ANP and others take over and you reach a steady state. There is slight increase in volume, but it isn't enough to kind of show up with edema. And so there is an aldosterone escape that happens. So whether you have when you have hyperaldosteronism, there is that aldosterone escape that happens as well.
Thanks, Ajay. I think we